First question, why isn't NRA paid for by insurance? It works. Thank you very much for that. It's a little, did not plant that question. The problem is it's not a drug, so therefore insurance is not required to pay for it. We encounter the same thing with nutritional products. If you get a prescription for Boost or something, there's some plans that will support it, some won't. It has to be justified. And the data right now, we don't have to justify it. So I can speculate on what's going to happen with this product. A big company like, I'm going to say Nestle, will probably take it over and lower the cost, and it'll be partnered out there as a hydration product. Okay, that's probably what they're going to do. It's making claims. Can't make claims on medical food. We're not making claims. We're improving quality of life. So this is where knowledge and information will have to be further developed. The clinical trial that Dr. Doss and myself will hopefully complete within a year or two will add to the support to get this paid for by insurance.
Well, I just want to mention, you can get 15% coupons. We have them available through our website, and Intrinsic Health is generous enough to offer that. So make sure you use those if you're going to use the product.
You know, another thing is, like probiotics. I put Enerade in the same class as probiotics. So does insurance pay for probiotics? This is for quality of life. I don't know if Enerade is going to lower serotonin levels. I'm not expecting it to. I'm finding that we use Telotrestat with Enerade. I'm finding we're using these drugs together, somatostatin with Enerade. We use somatostatin with Telotrestat. So all these agents that play a role in improving GI health, we now have potentially more choice. But I think the real data is going to have to come in the randomized prospective clinical trial. Yeah.
I've also had friends who have IBS, try my
Yes.
general gut feel,
So the kinds of comments we're hearing here are things that I can further expand on indications and things that I have witnessed: chemotherapy-induced diarrhea, immunotherapy-induced diarrhea. We're seeing improvements in C. diff diarrhea. I don't want to keep listing it, but I'm just saying we're improving hydration. And we're asking the colon not to resorb fluid. That's what NRA does, is it shuts off that volume of fluid that normally traverses the GI tract. It's not going to work in everybody. It's not. It can't. No drug's going to be 100%. I'm going to be happy if it works in a third of people, because I see it in about 70%, 80%. If I can cut that in half, just like Dr. Strasberg, I'd be happy with 30, 40%. Okay, we got to move on. Okay, with procedures, didn't need octreotide protocol. Which procedures do I not need octreotide protocol? Dr. Luke.
That's hard to know because it all depends on how much disease you have, how you respond in the past. So, for example, in general, for small things like dental things or like taking out lumps and bumps, you probably don't need it. It's mostly for people who are going to have general anesthesia that we start to worry about it.
Looks like we are outliving the cures. Is the data outdated? Is this the case?
Sorry, so in the context of...
We're outliving the cures.
Yeah.
So I think that what happens, the data that gets presented frequently is old data because it takes a while for data to mature. So if you look at current data, it's probably a decade or more old.
Yeah, totally agree. I think a lot of the treatments like PRRT, the curves that you guys saw today, the survival curves have not yet been reached, and we hope they aren't not reached for a long time. So those will take another 4 to 5 years at minimum before we even have averages. So agreed. I think the data that you see from some of the curves is probably at least 5 to 7 years old.
So this is a great Eric Lou question. Can different tumors in the same patient have different Ki-67s?
Yeah, so that's even worse than you think. The same tumor can have different Ki-67s. So it's a little bit like going in the neighborhood. So if you went to Manhattan, right, you're going to have like nice neighborhoods and maybe some not so nice neighborhoods. And that's how tumors are in the liver especially. So that's why if you take a single biopsy of a liver and you come back with a Ki-67, it's only part of the story. So it's tricky.
Does stress make the tumors grow?
I don't know the answer to that question. The problem is stress is actually a hormone response, or hormones will respond to your stress. And obviously these are hormonal types of things. We've looked at different types of hormone receptors in neuroendocrine. They do exist. I cannot tell you for sure because no one's ever done a randomized trial on inducing stress and then figure out what goes on. But as with everything, there's an element of everyone should still try to live every day in a better way, whether you have neuroendocrine cancer or any cancer or not. So stress-free, sleeping well, eating well, exercising, not smoking, drinking plenty of fluids. I mean, those are all real basic things. Drinking more integrated. Those are important things to do.
So I think in general, stress being that fight or flight, stress usually flares the symptoms. We guide patients to what works with controlling those symptoms. So indirectly, I think we can say yes, but no proven. But indirectly,
well,
yeah.
Let me actually make one quick comment. So what I would say is I can't tell you that it makes the tumors worse. However, there is a little bit of this kind of, you've heard this phrase, the 5 E's maybe. There's some nuances to it, but there are definitely emotional things that can make the symptoms worse. And so that is something to consider.
Okay, metastatic small bowel nets, liver and some lymph node, no surgery, had second PRT therapy. Is this an unusual protocol, having 2 PRT therapies? Is that unusual?
So 2 rounds of PRT?
So it said had second. Well, let's say it had second one, and then the question is surgery, can I still have surgery after the procedure if PRT is unsuccessful? So let's say 2 of 4.
Gotcha. So, I mean, I'll start with the first part, and I'll hand it off to Dr. Lou for the second part. Absolutely. So I think PRT, one of its benefits is that it can shrink tumors. Now, Dr. Anthony showed you data that perhaps the best shrinking therapy is capecitabine and temozolomide, the data that we have. PRT can shrink tumors in about 20% of cases. And so, absolutely, after a response to PRT, and I think if there's a tremendous response, I think surgery can certainly be considered.
Yeah. Actually, what that question is really about is about something called sequencing. There is no clear way of sequencing these things. A lot of these things we kind of deal with as we figure it as we go along. So I don't have an answer for you. My personal preference, just so you know, and I don't know if this is right or not, is to actually debulk the patients first, because I found that these things don't work awesomely for very large tumors, but it works really nicely for these little small tumors. And so I'd like to get them cleaned out first and then do the PRT, but that's just what I do. I cannot give you any more than that.
Actually, and to that point, there's actually going to be some data released soon from the Netter study that's going to actually talk about subgroups of patients who tended to benefit the most from PRT, and it's actually to exactly what Dr. Liu mentioned, is that folks with smaller tumors tend to actually benefit more, because if you can imagine, the radiation has to penetrate into a tumor to kill it. So the shallower the penetration, the more it can get in to actually kill the tumors. So that principle is being borne out. So I think philosophically, we're perhaps as a field looking at incorporating PRT even earlier in some of the sequencings.
Okay, this is to all of us. Why choose NET as your specialty? What led you or inspired you to this particular specialty? Dr. Doss.
It's a great question. I think from all the talks, what you can see is that taking care of NET patients is not just about treating the tumor, but it's about treating patients. And I think beyond the disease biology that exists, I think making a symptomatic difference for folks is really what sort of struck with me. And I think there was something about folks who've been told for many years, or as many of you had, that perhaps nothing was wrong, or this is a diagnosis that not many people have insight about. For me, it was a real opportunity to feel as I could contribute to some novel information and make a difference in folks' lives.
Mine is a long story, which we don't have time to tell. Some of you probably know this story, but I'm not going to tell you the story. It's a long time, but I'm just very blessed to be working here.
I would have to say octreotide or somatostatin analog, and I'd say it chose me. I started studying it, and then all of a sudden I saw that there was a career in it. Okay, up to 20% of tumors do not express a receptor, so they don't light up, but can they eventually become receptor positive or become syndromic? Can you?
Well, in my experience, in general, no, because they're different biologies. It's a little bit like asking a bald man to start growing hair spontaneously.
Okay, so if they were, the second part, so if they do remain negative, how do you manage them if they progress, if you don't know, if you can't see it because they're receptor negative? How do you manage them?
Yeah, but you have other scans. Right, yes.
Oh, no, but yeah, so you have CTs and MRIs, more traditional imaging modalities that you can use, and
Sometimes MIBG.
regular PET scans too. Yeah, absolutely.
Yeah.
And I think, naturally, if the somatostatin receptor is not there, then things like PRRT or the somatostatin analogs are not treatment options, but there's other treatments as well.
When people have Medicare, how do you recommend they go about paying for the octreotide lanreotide? Deductible is $1,500 a month for the injection.
Yeah.
So usually there's copay associations that can assist with this, so it's a negotiated. I would tell you get with a medical social worker and they can guide you through it. We have a specific person at UK in the pharmacy that bridges this world, and I can't think of one person that didn't get it that needed it.
Right. Yeah, no, I agree.
Yeah, the drug's available. It's
Yeah,
a
so sometimes just
negotiation.
calling
You
the
can't afford
company too helps.
$1,500. Well, maybe you can afford $150. It's whatever they negotiate. It's like buying a car in many respects. I mean, you've got to have an advocate out there to be pushing the industry. And usually, what happens is you're showing too many assets, and you can't start throwing away assets just to qualify because I think they require 3 years. I won't go into all the details, but there's rules about it. Okay, are there any genetic mutations linked to NET cancer, Dr. Lou?
Sure. The answer is yes, but not usually. So the majority of them are what we call sporadic, so just, lightning striking. There are some. So there certainly are this classic kind of multiple endocrine neoplasia, MEN syndrome. There are different variations of that. People tend to get pancreas ones. There have been various familial kind of genetic things that have been seen in families for small bowel as well, too. There's the group in Bethesda and Uppsala are studying these kinds of things. But in general, if you don't see it already, like my mom had it, my brother had it, my sister had it, then it's usually not genetic.
Any comment, Dr. Goss?
Yeah, just one more familial syndrome, von Hippel-Lindau. You can see also traveled kidney cancer, some pancreas and endocrine tumors as well.
But they're rare. Very rare. They're rare.
How often should one get a gallium dotatate scan? Just the right amount, the right number.
Yeah, that depends on, everything depends, right? So it depends on how you are, depends on how your disease is. So in general, for me, I usually order them between every 1 and 3 years because I've been doing this for a long time, and when I ordered them more, I didn't get any more information. So it depends on what you're looking for.
Is it best to watch and wait versus somatostatin analog therapy to suppress growth when there was minimal activity noted in both axillary and inguinal nodes post-primary removal of the bowel and bowel resection?
Yeah.
Axillary.
Yeah, no,
I think that person needs to go to a NET specialist.
Yeah, agreed. I agree. I mean, I think that's the $1 million question.
Yeah.
That is like when to pull the trigger for treating. And actually, I think just, if I'm not mistaken, maybe a week ago, there was, again, a retrospective grouping of studies that was done that suggests perhaps earlier treatment may be better, but there's never been a randomized trial. So I think, again, as Dr. Anthony said, just talking with your NET doc and about what might be the right interval to get a scan, because clearly if it's growing slowly, even if you wait 2 months, you can certainly make a difference to intervene later on down the road.
Okay, this is a critical question. If kidney function prevents PRT, what are your options?
Well, that's an interesting question.
It's a great question.
I'm not totally convinced that PRT is really nephrotoxic. Okay, so here's the deal. The general teaching is that PRT tends to whack your bone marrow and your kidneys. Okay, however, the geniuses in Europe have figured out that if you can block the kidneys, you can actually prevent a lot of that stuff going on. It is genius. It was amazing. So there was a slide. We have a friend named Dr. Krenning who did this a lot, and he has a big slide. He says PRT is not nephrotoxic. Is what he says.
If you get amino acids.
If you give amino acids, correct. If you do it correctly. And so I don't know the answer to that question. So and I hate to say this, I've been slowly pushing lower and lower. So people who have worse renal function, I've just been giving it, and I just hope it turns out okay. And so far, so
I think the Mayo Clinic gave it someone on dialysis.
well,
Yeah.
He
Yeah.
So it's actually healing that.
Yeah, just talk about it.
Go ahead.
Yeah, so I totally agree. I mean, I think we always want to err on the side of caution because, again, PRT is excreted or broken down through the kidneys. So really what you worry about is if the kidneys aren't working, the PRT drug hangs around in the blood too long and causes bone marrow problems. And so we're the same way at Vanderbilt. You know, every case is unique, but we've also been treating sort of lower and lower. And sometimes we'll start at half dose, that first dose, to see how folks do, make sure the side effects are okay before we go back to full dose. But in general, we've also seen that it's really well tolerated.
Okay, I'm going to answer this question. It says, is NETs incurable? So if I let Dr. Lou take it, I know what the answer is.
Sometimes.
So when we talk about NETs, we have to be very, very specific. If we can get it early enough, it's curable, thanks to Dr. Lou. Thank you, Dr. Lou. The only way you're going to cure this is with surgery. And sometimes it takes time after surgery to know whether you cure or not. You think you got it all, and it depends on the stage. So the lymph nodes with the margins, with differentiation, peritoneal invasion, perivascular invasion, there's a lot of characteristics that we look at on the path to determine how to follow that person. So early stage. So I think where this question is really headed is the fact that most patients do not present in that early stage. It's usually by accident. They do, but it's very small. It's usually when they're in getting some other procedure and they find it incidentally. So that's the best case of scenario for early detection. But so when we look at the other way, we can think about NETs when it's not in the realm of the surgeon to cure. We can think of it as a chronic illness. We can think of it as a disease that can be controlled like diabetes. And that's what Dr. Dawson and I are really focused on, and Dr. Lou, but we're really focused on controlling the symptoms, controlling the disease. Those two really go together. If we do a good job with quality of life, quantity will follow. So we would be thrilled to see diabetes cured in our lifetimes. We would be thrilled to see neuroendocrine metastatic disease cured in our lifetimes. But we can only say that the outcomes are getting better and better and better.
And I mean, that analogy is actually really good. You guys don't know this, but juvenile diabetes, type 1 diabetes, used to be a uniformly lethal disease. If your kid got it, it was worse than having cancer, childhood cancer. They were dead in 6 months, and you watched them starve and die to death. And now there are many, this is in the 1919, before insulin was invented. Then in 1921, all of a sudden, since then, diabetes has become a chronic disease. And there are many people with type juvenile diabetes who are now 60, 70 years old. And so it's the same type of philosophy. If we can do that and keep you going, that's what we try to do.
Okay, will a gallium scan show anything if your primary or all tumor is non-functional? So this is a critical understanding between receptor positivity and functionality.
Yeah, so exactly. So as long as your tumor expresses somatostatin, it will show up on the gallium scan. So the functionality is different from the receptor. The receptor is actually expressed on the surface of the tumor. The functionality is actually what a hormone internally produced by the tumor.
So one of the things that was discovered in the early 1960s was the fact that these neuroendocrine tumors took up amino acids, and we called them apodomas. This was amino acid precursor uptake and decarboxylation. That's a long, complicated term, but that's what we called neuroendocrine tumors 1961, apodomas. Apodomas. So as somatostatin story came about, we saw that these tumors were not only concentrating amino acids and decarboxylating them, but they expressed a somatostatin receptor. So that became the hallmark of defining what a neuroendocrine tumor is. Now, some non-neuroendocrine tumors express it. Lymphomas, melanomas, and some lung cancers and breast cancers and stuff will express the receptor. But once we have the histologic diagnosis of neuroendocrine tumor, then I would say 9 out of 10, maybe 95 out of 100, it pretty much should express, and these are gut. I'm talking about small bowel gut, because the pancreatic neuroendocrine tumors, the receptor expression may be just a little different. We have to be sensitive to the origin.
Wait, if I can just elaborate a little bit on that.
But, yeah.
So the analogy I like to give is like this. It's like this. You can have two men. One can have a lot of hair, and one can be bald. Okay? So if you're bald, okay, but you can also be very, very loud, or very, very quiet. And so those two things are not related at all. So that's how the functionality and the receptor status are totally, completely different. Now in this case, I have a lot of hair, he has less hair, but we're both loud. So just think of it that way, okay? They're just different kinds of features.
So what I will say is that the neuroendocrine tumors that we're talking about today are derived mostly from the endodermal layer in the embryo, and we see tumors that are forming in the small bowel, pancreas, and small in the lung. There's another type of neuroendocrine tumor that comes through the neuroectodermal plate. It's a little bit different. It gives rise to adrenal neuroendocrine tumors, pheochromocytomas. Anyone heard of pheo? Or medullary carcinoma of the thyroid? So these tumors typically do not express the somatostatin receptor. And paragangliomas, exactly. Paragangliomas, pheos, medullary carcinoma of the thyroid. These tumors have what in common catecholamine transport protein in their surface. So we measure that with meta-iodobenzylguanidine. That's a very fancy term. We call it MIBG. You call it MBIG if you want to. I think it's probably the biggest way. It's probably the best way for people to remember that big scan or something. People will know it. But we don't do up front, we don't do somatostatin imaging on a pheo. We do MIBG. We don't do MIBG on a neuroendocrine tumor of the gut, but we have found that some that are in the gut, if they're negative for somatostatin, the MIBG scan may show it. Almost.
Yeah, and that's a great point because actually there's an ongoing trial at the NCI for paragangliomas that express somatostatin receptor using PRT with lutetium, and that's ongoing.
What determines the timeline between PRP treatments? Why 8 weeks? Great question.
So the reason we do the 8 weeks is because the major problem with PRT is it whacks your bone marrow. So it's a little bit like chemo, not quite, but basically it goes down and it comes up, and usually it takes about 8 weeks for your bone marrow to recover. If you do it more often, and this is from very classic nuclear medicine, radiation kind of studies, if you do it more often, it will be cumulatively worse for you. So you have to have enough time to recover. I just want to make one comment about the whole thing that Dr. Anthony just said. You may not have understood anything he said, but it just goes to show you how important it is to see someone who does know what they're doing, because he can put all that stuff together and really help you with all the different facets, way beyond what a general oncologist can do.
So the question is there anything you can do to get your platelets up? Unfortunately, no.
No, that's not
Time. We don't have growth factors that are predicted to be. Okay, tell me your growth factor story, and I will start
your spleen.
I'm not sure we're going to be taking out. I think the FDA would freak. And let me just say, this is a little jovial, but I'll say I got to sit in the room for octreotide attack by the FDA in the 1980s, and here I came through all the toxic chemotherapy, and now I'm hearing it argued hormonal therapy, and the FDA jumped on the sponsor at the time at Sandoz because these people were getting gallstones. These people were having their disease control, their symptoms controlled. We didn't know about disease control at that time, but because a drug, you injured somebody, you created a gallstone, and it was 48% was what was in the acromegalies were included. For some reason, acromegalics form gallstones more so than anybody else, and they I thought I was talking about a drug that was the worst product in the world because people had to have their gallbladders taken out. Some of them would be at risk for that. I was horrified. I was horrified because you could die from myelosuppression.
Anyone taken Coumadin before?
Yeah.
Or warfarin? That's a rat poison.
But so everything is relative. So if we started taking people's spleens out, I think that might be worse than taking gallbladder. I don't know. So anyway, that's just a little joke. Okay, how do you manage tumors that do not express somatostatin receptors? Have you taken a spleen out for low platelets and PRT? Okay. How do you manage? Yeah, you always offer. Well, I'll be as transparent as possible. I think people who get into platelet problems are usually older people who've had previous treatment. So those are we have to be real careful. People prior alkylating therapy, temozolomide, how are you approaching people who are on alkylating therapy thinking in the future? I'd love to hear Dr. Doss, because this is something I think about every time I go to clinic.
Yeah, it's a fantastic question. I think a lot of it has to do with tumor bulk. So sometimes, actually, I just had a patient last week who actually started initially on PRT, a pancreas neuroendocrine patient, grade 2, lots of disease in the liver, got 1 dose of PRT, having unremitting fevers, kind of release of cytokines, not looking good. So we ended up switching this patient to capecitabine and Timidar. 3 cycles later, 70% of the tumors in the liver are now gone, and I think we revisit PRT. So I think a lot of my decisions about when to use the alkylating agent are based on tumor bulk. Platelets were okay.
So what happens, we talked a little about clinical trials and the observation after that. So the clinical trials for the Lutathera for PRT didn't include people who had had previous alkylating therapy. So the incidence of myelodysplastic syndrome and leukemia from the alkylating therapy, it was only I think there were 2 cases, 1 plus minus 2, and that was out of maybe 150 total. So that's pretty small. So the package insert says it's less than 1% or so, very tiny. Now, if you go into Europe, where they've been doing PRT for 25 years, the French have reported a much higher incidence of leukemia and myelodysplastic syndrome in people who have gotten alkylating therapy. Now, with that history, we have to put in perspective and clearly respect what chronic alkylating therapy puts people at risk for. So it's a decision that the provider has to have that discussion with the patient, know what the risks are, and decide what's best for them.
And I think a lot of that, too, for alkylating therapy comes to finite periods of time. So I think a lot of times you'll see folks, our philosophy is you hit the tumor hard and then you back off and you let the therapy work. You don't keep people on therapies. And I think that opens up a lot of options down the road. Because, for example, if you're on the capecitabine and temozolomide and it works, I usually don't give more than 4 to 6 cycles and then back off for that.
Very respective. So how do you manage tumors that do not express metastatic receptor?
Wait, before you go on, let me say one thing. So I will say this again. If you can hear these two men speaking, you can see how complicated this is. You really need to see someone who knows what's going on. However, the one thing I would disagree a little bit on, so what Dr. Das says is true, but that's only because this drug, temozolomide and capecitabine and PRT, have a long-lasting effect. There are drugs and diseases like cisplatin and etoposide where you start to turn that thing off, that disease will come back. And so it all depends.
So we're going to revisit this question again. How do you manage tumors that do not express the myostatin receptor? We've talked about the MIBG therapy. It may express the catecholamine receptor. You can do surgery. You can do capecitabine potentially, temozolomide. You can do maybe everolimus. You can maybe do sunitinib. So you just can't do PRT in the form of Lutathera.
Well, let me make one comment. I don't know if you said this, Lowell, but I also still give somatostatin analog for even the disease that doesn't express it, because sometimes what can happen is you can actually reduce kind of growth factors too. So they can behave very differently. I used to think that, if it was negative, I never gave it. And I started giving it because someone had talked about it and presented something, and there is some benefit.
Has any relationship been studied or noted between NETs producing serotonin and psych, mental, or mood disorders? No. So the best data comes from Canada. The Canadian system has, they presented at NANETS a few years ago, probably the best review of SSRIs in their system. They presented, you remember that? They presented the history. Far away.
Let me tell the story. So there's a surgeon up in Calgary. Her name is Janice Pasieka. She's a nice lady, endocrine surgeon. And what she found out was that her schedules were struggling with all her neuroendocrine patients because they would forget to come to the appointments. And they would complain about, being angry. Does this sound familiar? For whatever reason, you get angry and you don't even know why, right? And so that happens. And so she started studying this with her patients with surveys and stuff, and she found that, in fact, there was a very real kind of emotional aspect to it. The traditional teaching is that the serotonin from the blood doesn't get across the blood-brain barrier. However, there's clearly some kind of interaction involved. So this whole kind of carcinoid rage or carcinoid emotional thing or blood pressure, it may not be the serotonin. Maybe there's factor X which is doing this. So we describe maybe like 6 or 7 hormones that we know really well, but that's probably like 6 or 7 hormones out of 7,000 hormones that your body produces. So I've just become much more humble about this, and however you describe it, it's fine.
So the question I get a lot, are the SSRIs contraindicated in serotonin? Is that true or false? What do you think about that?
Yeah, I think
Antidepressants.
Antidepressants.
Yeah, so I think there's a recent publication from Memorial as well that showed that SSRIs are safe and they do not worsen carcinoid syndrome and can be utilized. So
that's exactly what my experience has been. There's always this fear, and I'm going to really talk about this afternoon, so I won't go further into it.
And so
okay.
One thing we should mention too. There are a lot of myths about neuroendocrine. A lot of myths about neuroendocrine, which is why
Can Ki-67% change as tumor progresses? Is that a myth?
that's an interesting thing. So
It's not a myth, or is it a myth?
Yeah, can Ki-67 change? I don't know the answer to that question because I only, when we started doing our study and found that they were all different, it was hard to figure out. So the only test that absolutely works 100% of the time is the test of time. And you figure out how these things behave over time. And if they start to act like they're misbehaving, well, then chances are they're misbehaving. And if they're acting like they're not misbehaving, then you're okay.
Well, can a non-functional tumor become functional? I'll let you answer both of these, but this is a coupled AB.
Sure. Yeah. So, and actually, Dr. Liu and I share a patient and it's interesting because her disease is actually evolving and it's becoming sort of more aggressive. Now, I think Dr. Liu raises a great point that did she have a clone that if we'd biopsied it differently initially, we might have seen that more aggressive clone. That we don't know the answer to. And as far as for that latter question, I haven't seen sort of.
Yeah.
You're too young, that's why. I used to be that young Asian doctor. So the answer is, in general, Dr. Doss is right, in general, no. However, unless it does. Let me just tell you an example. So I've had a couple of, I learned these lessons very brutally. I had a patient who had non-functional pancreatic tumor, and then we gave her PRRT, and she turned into a roaring insulinoma. And I didn't know this until I talked to my friends in Germany, and he said basically, yeah, we've seen that before. What happens is these functional tumors, they kill off all the sister cells, like the glucagon cells.
We have a case undergoing that right now.
Yeah, it's hard. And then they start to secrete tons of insulin. You can't stop it. It's tough.
It's amazing. Okay, so my experience with it, and I'm going to sort of kind of tell you that a functional tumor can sometimes start making multiple hormones. It's not common, but we always think about if they're making one hormone, and this is more applicable to the pancreatic ones. If they're making glucagon, possibly they could also be making some other peptide. So we screen for all of them to see if, and they can turn them on and turn them off. But I'll say when you start thinking about functionality, it depends on how you define it. So yesterday I see a gentleman in my clinic who is absolutely opposed to therapy. Okay, and it's not religion; it's just that he doesn't want to be inconvenienced with treatment. And so to be honest with you, I'll take care of anybody. In terms of, I'm not going to force a treatment on him. I'm going to talk to him about the pros and cons. And so I've been watching this gentleman for several years. And so he wasn't functional before. Yesterday he was really functional. So what did that mean? It means his tumor's progressing. It's not that his tumor wasn't functional, but the functionality may be related to tumor bulk. Okay? So that we want to control symptoms. And I don't think I've got another person that I've ever watched the natural history on since maybe, I don't know, I can't, I'm sitting there. I can't, I know. And so I spent an hour with this gentleman really counseling. Again, it's probably, these are the people you spend the most time on because they have to really have the buy-in of understanding what the goals are. And we talked about short-term treatment. You work with each person on their terms. Okay, tempo of growth. Tempo can be slow even if new tumors emerge. Please explain.
Yeah, so typically actually when new tumors emerge, typically that's not a slow tempo. I think when we have existing tumors that change by small periods of time, I think that's what I was referring to. And, tempo depends on sort of the flavor of the neuroendocrine tumor. So the carcinomas that Dr. Liu just mentioned, they can really just blossom and grow incredibly quickly. Kind of the minute you stop therapy, these things are growing. And so tempo, I think, really refers to existing tumors that are changing very slowly rather than new tumors.
Any comment, Aaron?
Yeah, no, I completely agree. So those new tumors, they're not new tumors. They were always there. It's just they finally have risen above the level that you can detect them. So when we first started doing gallium, it was a problem because we thought, oh, you have all these new tumors. Well, yeah, but they were always there. So it's just it's a little bit matter of figuring these things out. But new tumors are real. But again, you can have a new tumor in your earlobe, and if it doesn't hurt you, well then it's okay.
Okay, so let me throw a hypothetical case at you. So we have someone who's had their primary in the gut resected, and there's one lymph node that is bothersome. For some reason, it wasn't recognized at the time. You do the gallium, you see a single lymph node. You watch it over, a couple of years, and it slowly grows. Each time you scan, about every 6 months, it's up by a few millimeters. So over a year and a half or so, it's up by maybe a centimeter. So would you go after that lymph node because it's getting a little bit bigger? It's in the periaortic space, or when would you intervene? How big would it have to be before you would intervene? And they're asymptomatic.
Right. So let me explain this. So the question that Dr. Anthony asks is actually much more nuanced than you think. What he's saying is basically, okay, you got this little ditzel thing. Is it worth going after? That's what he's trying to say. But it's actually much more nuanced than that. Because if you have one that's going to cause you problems and cause problems with blockages and stuff like that, and there are two kinds of this is too much in the weeds, but there are different kinds of neuroendocrine tumors in your mesentery, which is that support tissue I told you about. There are little round ones which are perfectly well behaved, and there are angry ones that are scraggly and like log shaped, and they will cause different problems. If you have one in your back, for example, in what he called the retroperi-aortic space, it's different. It doesn't usually cause people problems. I can get those, but it's not really worth it. So for example, if it was creeping along at a couple of millimeters every couple of years, I wouldn't freak out about that. I would just wait, because doing an operation every 15 months in someone is no fun. Have I done it before? Sure. I once did an operation. I did 7 operations on this guy in 1 year, and he's still alive. Okay, so it was worth it. But to go after a tiny thing that's 1 centimeter is just probably not worth it, because what happens is, don't fool yourself. Those things are not going to kill you. They're not going to hurt you at all, in fact. What's going to kill you, there are 3 things that kill neuroendocrine patients, and forgive me for being morbid, but it's important for you to understand this. 1, either you have a terrible mechanical problem, like that story I told you before, like blockages, vessels, whatever it is. The second one is overwhelming hormone, just like raging hormone that blows out the valves in your heart, which Dr. Anthony will talk about, or insulin, where your glucose is bottoming out constantly. And the third one is when it eats away at your liver. And when it eats away at your liver and you have no more liver, you die. That's how it works. So my goal is always to prevent those 3 things. I mean, are there exceptions? Of course, but those are the 3 big ones. And so if I can prevent that, then I can keep you going.
Okay, a question regarding Cas6-7 and proliferation. How long does it take a single cell actually to divide? We got to be very specific. I guess we're talking about a neuroendocrine single cell to divide.
Well, to divide, it only takes a couple hours. I mean, for any single cell. The major question is, how many of those cells are dividing at any one time that would cause in order to make the tumor like big enough to cause you problems, right? And so if you look under a microscope, it's actually quite amazing. It's quite beautiful. The DNA separates, they split into 2 things. You have daughter cells. It's really quite lovely. But the truth of the matter is, you don't see it that much in the tumor unless it's very angry, like the carcinomas that Dr. Das was talking about, and those are terrifying.
So I think what this question is also getting at is a concept that we call tumor growth rate.
Yeah.
So you want to address that?
So I think this has been touched on in a few of these examples, but the tumor growth rate. So for example, when a carcinoma, a neuroendocrine carcinoma grows, its Ki67 replication rate is in the order of weeks, because that's how long it takes for these tumors to double. If you're looking at a well-differentiated neuroendocrine tumor that changes by a few millimeters every 6 months, then naturally you can assume that its growth rate is over the period of months. And so that tumor
Or years sometimes.
Or years, yeah, exactly, because sometimes folks never need treatment because the rate of growth is just so slow. So I think of growth and the identity of the neuroendocrine tumor as sort of tied together, because really it's the nature of the neuroendocrine tumor that identifies its pattern of growth and actually identifies what is concerning given what type of neuroendocrine tumor we're dealing with.
Biology is king.
So this is really the kind of discussions that we have in our tumor boards whenever we see someone for the first time. We're looking at the pathology. We're not looking at a report that's been generated by a pathologist that's not in the room. We're looking at somebody who is looking at that specimen in the context of that person's symptoms, their presentation, and their scans. And what we're trying to do coming out of that, we're trying to predict what that tumor growth rate is. And so we do an expert opinion about what that's going to be. Then we have to see if we were right or not. And I would say that any time that we're wrong, it's because of the thing that Dr. Liu talked about. We have a sampling error. What we saw is very objective and concrete. What we witness is something that then translates into that person in terms of just the limitations of what we had at the time that we predicted what that biologic behavior was going to be. So we're always suspect because cancer is a very wily enemy, and just because we think we know, we never assume.
Right. Let me just give you an example. So in that study I told you about where I made the pathologist cut into every one of the tumors, she also cut into the primary tumor. The primary tumor, and this is from the small intestine, so this is just one example. But in the small intestine, they were almost all low grade from the small intestine. So like maybe 1 or 2%. But that tumor's been there for like 10 years, right? And it's always small. But then the one in the liver could be up to 30% and behaving differently.
I think that also goes to the monitoring. When we start, for example, a patient on a somatostatin analog, what I like to do, even if it's a grade 1 neuroendocrine tumor patient, is 3 months I'll get a scan, just to actually look at how the biology of the tumor is evolving, and is there a component that we've missed in an area that we weren't looking at.
Okay, I will end the session with this question. Chromogranin A question here. Okay, so this person's been operated on, and it's been 6 months, and the chromogranin A level has not fallen. What do you do? How often does that occur? Do you just monitor it? What does it mean? Is that what you'd expect?
Yeah, okay. So chromogranin, I have this mixed feelings about chromogranin because if you guys know me, I trained in Sweden, and my mentor was the one who championed chromogranin. And so he thinks it's amazing. The only problem is it doesn't work that great. So let me explain. It was amazing for its time, I would say. It was amazing for its time. But chromogranin is a blood hormone that's usually secreted by neuroendocrine cells. And if you have a ton of neuroendocrine cancer, then usually a ton of chromogranin comes out. That would make sense. The only problem is there's a tiny little purple pill that makes chromogranin go up all the time. So if I gave every one of you some like Nexium, Protonix, Prilosec, whatever, your choice of that kind of pill, all of your chromogranins will go up. So then all of a sudden test becomes meaningless. And I dare to survey that probably 50% of this room takes some kind of, antacid kind of medication. So, and it's very routine after surgery for us to give that medication to help prevent what we call stress ulcers. So if you're not on the medication and your chromogranin hasn't go down, then it doesn't matter. So the biomarkers, no one dies of an elevated chromogranin. Nobody. However, people can die of tumor burden and stuff like that. So then you should really figure out by scans what's going on. Okay, so you have to know how to use the marker.
100% agree. So I think there's a lot of controversy. Even if you look at the NCCN guidelines, it's chromogranin measurement is a category 3, meaning that you flip a coin and people are going to be on different sides. So I personally don't actually use a chromogranin to surveil my patients.
Thank you all for spending your Saturday.
Thank my wife.
Isn't that the way? My wife says thank you as well. Definitely. Well, all right. I think we better stop horsing around up here. No, what an amazing morning. I want to please give everyone